I had to turn the computer off and then reboot and start again. So in spite of the fact that we've been now Zooming for 2 years in a variety of ways, but it's nice to be here with everybody. I will, Erica, you disabled screen sharing.
Let me just a moment. Oopsie. I didn't disable it. I just didn't enable it.
Let's try this again. All right. Okay. There we go. All right. Let us begin, if I may. And I'm sorry again, we're a few minutes late, so we can take whatever amount of time that we need to get going. Erica was very clever in her way of advertising this program in terms of asking you the question, which is sort of the fundamental basis of all of this, is what happens? You suffer a fall, you go to the hospital, you're treated, you're transferred to a rehab center for 3 weeks of rehab. And then weeks later, the bills start pouring in and you learn that you are not actually an inpatient in the hospital and the Medicare only covered 80% of your hospital bill, and they're not covering your rehab stay at all, and you owe thousands of dollars to the nursing home and the rehab. So the question is, how did this happen? Well, let us look at, let me go back here. I want to talk about the background information here. I'm sorry, I had to make the slides a little bit bigger. Okay. I want to give you just a little historical perspective on this because I think it will help to sort of frame it and understand differently. As far back as the 1980s, Medicare was attempting to get a handle on its costs. And so they introduced something in the early 80s called diagnostic related groups. And what that was Medicare decided they would pay a fixed amount of money for a particular diagnosis. So if you had a stroke or a fractured hip or you were having a knee replaced or any number of things, they gave the hospital X number of dollars to pay for X number of days for people who had that particular diagnosis. And I remember back at the time, I was director of social work at a community hospital in Butler, Pennsylvania. And the person who was the general counsel and I went on the road and we literally just went at all these community meetings and people were just astonished and they couldn't believe this is happening. And they thought it was the hospital was trying to throw them out early. So it was really hard to explain to people, you know, when you could stay for literally weeks on end of a stroke and now you can only stay for 5 days. And then following that, to make it a little bit more specific, Medicare hammered down even more back in the sort of the mid-1980s, and they moved to what was called a 24-hour observation program. And so essentially what that was is the same message to the hospitals. But they said, you know, if you're not sure whether or not this person should actually be admitted as an inpatient, we're going to give you 23 hours and 59 minutes to make that decision. Well, you can imagine the pressure. And I was at a very large hospital system in the Southwest in Phoenix called Samaritan Health Services. And, you know, people came in for just every number of things you can imagine, from the most traumatic injuries to, you know, some of the more mundane sorts of things. And we literally at that point physically set aside a unit in the hospital. And I think back on it and think how funny it is that people were actually sort of looking at your watch. What do you think? We've only got like 3 hours and 27 minutes left or something. But what it required was that every single morning, in fact, sometimes twice a day, we would have to have, my social work staff would have to have meetings with hospital administration to say, well, what are the discharge plans? How can we get this person out of here? Because we only have 23 hours and 59 minutes. So what is observation status? It's a billing code basically used to protect, that hospitals use to protect themselves from the penalty of admitting people who don't qualify for acute care. And as I said previously, this code has doubled in the past 5 years because as Medicare cracks down, more and more hospitals are trying to be, basically protect themselves from paying a penalty for Medicare or getting a stay that's not covered. So it's basically a designation that the hospitals use to decide whether they're going to admit you as an inpatient. So people who receive care in a hospital, even if you're there for overnight or for several days, you may come to learn that you're not actually admitted as an inpatient, but instead the hospital has classified you as the observation status, which is actually an outpatient category. And this can happen even if people who are extremely ill and spend several days in a hospital. So you can be in a gown, in a bed with a bracelet on your hand, and you're still not necessarily an inpatient. And we're going to plumb down and talk a little bit more about that. But, sorry, back here. Because what has transpired in the past probably 24 to 36 months, the use of this has become increasingly used among the hospitals. And what started out, again, as 24-hour, in some cases, it's morphed into a 72-hour period. So you could literally be sitting in the hospital for 3 days and without being admitted as an inpatient. And the reason is because Medicare has now basically said, we do retrospective reviews on the medical records of all of the Medicare patients that have ever been in your hospital. And if we determine after the fact, retrospectively, that that person should not have been admitted, the entire stay is denied. So the amount of money that hospitals have potential to lose is just huge. So as a result, they've become very defensive and very proactive and are basically saying, okay, we're going to use this observation status as long as we possibly can. So I want to do just a quick review because some of you were on the earlier talk where we talked about Medicare, but Part A pays for a hospital stay when you're actually formally admitted to the hospital. And under Part B, what's paid for there are emergency department, observation status, outpatient surgery, lab tests, etc. So why does it matter? Well, people in observation status are charged for services that Medicare would have paid if they were admitted as inpatients. So things like medication or really expensive tests have the potential not to be covered if you're in an observation status. And so equally important, I think, to people our age is that if you're not an inpatient, and we'll talk a little bit more in detail about that, if you're not an inpatient and you need nursing home care, Medicare will not pay for a nursing home if you have not met the criteria for the 3-day inpatient stay that they require. So observation status doesn't count for any of that. I mean, the rule is you have to have had they call it 3 midnights. So you have to have been in the hospital for 3 overnights. So 3 days you've had to have been there past midnight, and they don't count the day on which you were discharged. So in effect, that's 4 calendar days. The challenge with the observation status, most people do have Part B, but I will tell you, because of the fact that I do consulting with work one-on-one with people, there are some people who basically decide not to get Part B because it's really expensive and it's tied to their income. But if somebody does not have Part B and they end up in an observation status, they are responsible for the entire hospital bill. So there is absolutely no payment whatsoever because Medicare A is not covering it. So the key part for Part A, and that we need to know in this venue, is that A pays for acute hospital care, skilled nursing care, and inpatient rehab. So again, A pays, and I'm sorry, I'm being a dead horse here, but medical necessity really comes into this. And again, it goes back to how Medicare looks at the chart. Was it medically necessary? Did they need acute medical care? And if the answer is yes, and it can be demonstrated, then a person can be admitted to the hospital and Medicare will pay. If in doubt, categorize these people as observation status and then go from there. So if you're A, and if you're going to be admitted, legitimately admitted, then your only cost for this stay is $1,500. It's the upfront cost that Medicare pays. It's called the deductible. So again, you're an inpatient when you're admitted, when the order is written stating that you require highly technical acute inpatient care, not just that you're occupying a bed. Now, back to Part B, because this is going to be important in an observation status. Part B pays for physicians and ambulance, etc. They also pay for some of the high-cost experimental drugs, which could conceivably be used if you were at the hospital. And the key here is that they also pay for charges in the observation status. Most people have a Medigap plan, and the Medigap plan then would pay the other 20% because B only pays 80%. So I know people for whom this has happened, and it happens oftentimes if a person goes in through the emergency room and they're put on a gurney somewhere and someone's trying to decide, they haven't figured out a diagnosis for them yet. And so conceivably they could be moved to a room. They could even be moved to an intensive care unit bed, but this decision still has not been made whether or not they're going to be admitted. And so they're sitting in a bed, they're there overnight, they've got a bracelet on, they've got a gown on. Well, who wouldn't think that you were admitted as an inpatient? I mean, when you've got a gown and a bed and a bracelet on your arm, of course you think you're an inpatient, and in reality you may well not be. So the severity of illness, is this person sick enough? These are the two major criteria. Is this person sick enough to need inpatient care? And are the services intense enough or difficult enough that a hospital inpatient unit is the only place where a person can get them? And if you imagine this is not literally true, but if you imagine that that's written on the palm of the doctor's hands to say in their head, is this severity of illness enough to put them in? And are these intense enough to require inpatient? We can only do this if they're in an inpatient bed. So because Part B has co-payments, as I said, the Medigap plan is what pays the 20%. However, these Medigap plans vary. And the one thing that happens when I'm working with people individually, when they're signing up for Medicare for the first time, and or they're looking, at annual enrollment to look at their supplemental plans, one of the things that I really stress is that they look at these plans that make sure that they cover the Part B coinsurance and copayment, because the observation status happens so frequently. I would, try to advise them those plans are a little bit more expensive, but they're certainly worth it, because if you're paying 20% of all these costs, it is just an exorbitant amount of money that most people couldn't readily afford. Just to give you kind of a specifics, this is hard to read, but on the, I put the link, and I just wanted to say, if sort of a divergence here, we would make slides available to people. If they want a copy of the slides, we can send those out to you electronically after the tomorrow or the next day after we have finished the talk, and then you just would email the Palisades Village office. But as you can see, just back to the Medigap plans, if you go down to the second column here, Part B coinsurance, if you let your eye roll across there, most of the plans do cover it. But as you'll see with two plans, K and L, K only pays 50% of that and L only pays 75%. So you'd want to make sure that your Part B coinsurance and copayment is included when you pick a Medigap plan. So let's look at some real-time examples that sort of make all this come together, I think. And here's some situations, and we'll walk through whether the person's really admitted or not. You're in the emergency room, and then you're formally admitted to the hospital with the doctor's order. You are outpatient until you're formally admitted as an inpatient or your doctor orders an inpatient. Your doctor orders inpatient. So your Medicare A pays for your stay and Medicare B pays for the doctor's services. Second scenario is you visit the emergency room, you're sent to the intensive care unit for close monitoring, but your doctor expects to send you home the next morning unless your condition worsens. Your condition resolves and you can be sent home. So are you an inpatient or an outpatient? You're actually an outpatient and you're in observation status. Medicare A pays nothing. Your doctor's services, Medicare B then pays for the doctor's services and then the outpatient services like lab tests and IV. And the next one, you come to the emergency room with chest pains and the hospital keeps you for 2 nights. One of those nights is spent in observation, and then the doctor writes an order saying, okay, we need an admission. We need to admit this person because I really need to see what's going on, and I feel like they have to be inpatient. So you're outpatient until you're formally admitted as an inpatient or the doctor writes the order. So your first day, when you spend that first few days in the emergency room, that's going to be covered by B. But then when you're finally admitted, then your inpatient stay is covered by A. So let's look at another one. You go to the hospital for outpatient surgery, but they keep you overnight because your blood pressure spiked. So your doctor doesn't write an order to admit you as an inpatient. So you go home the next day. So you're qualified as an outpatient through the entire time. A pays nothing, but B will pay for the outpatient services. They'll pay for the surgery and the other the services that you've had. And then finally, a doctor writes an order for you to be admitted as an inpatient. And then the hospital later tells you that they're changing that they're going to change your status, even though the doctor has written it. And this becomes very, very, very controversial. And I think it's caused a lot of difficulty with the hospital administration and actual doctors, because the doctor may say, you know, I want to put this person on the inpatient unit. And they're told basically, no, we don't agree with you. They're not sick enough. So the person gets discharged. And they end up never being admitted to the hospital. And again, the Part A pays nothing. So I want to tell you why I think this is happening. I told you previously, I think one of the things that's going on, of course, is the Medicare has just become so much more stringent. But the other thing that happens, particularly in the last scenario that I just outlined, is that hospitals are increasingly relying on hospitalists. And I don't know how many of you have heard that term before, but hospitalists are basically physicians who are employed by the hospital. So they're employees, just like the nurses and physical therapists, etc. Now, you think about employed by the hospital, then you basically, their allegiance is to the hospital where they get their paycheck. Most of the emergency room doctors throughout the city are doctors who are contracts. And we are in a day when very, very few primary care physicians will actually follow their patients in the hospital. It is just not cost effective for a doctor to get in her or his car, drive to the parking lot, log in, come to the nursing unit, ask what's going on, know how to use their electronic medical records service, which is different. Sibley uses a different medical records than Georgetown and GW, and it just isn't cost effective. So consequently, what happens is you don't have somebody who knows you. You don't have somebody who knows your history. They don't know your living situation. They don't know that you've just fractured your hip possibly, and you live on a 3rd floor apartment and you have no support systems. You literally land in that hospital with, even though you're asked about those things, nobody really knows you. And so that's one of the problems, I think, that there's often that conflict between the hospital and the doctors, because you don't have somebody there who says, oh, come on, you need to take this into account. And here is the list of the local hospitals. I don't know about Howard University, but I know that all of these other hospitals that most of us know the names of and some of us have been to, all use the hospitalist model. And again, there's nothing wrong with hospitalists, but one of the downsides, when you're one of the hospitalists, they rotate every 3 days. So when you think about how long a person could conceivably be, you could cycle through 2 different rotations of the hospitalist. So now you've got one for a day, and then on day 2, you may have a different one. So that creates yet another challenge in terms of knowing the patient and having some background in which to know, should these people really be admitted? Can we, make a justification for that? So back in 2015, Congress realized that this was a real problem for people just in terms of financial liability. So they enacted, you'll notice only a bureaucrat can make up this title, Notice of Observation and Treatment and Implication for Care Eligibility Act. I want you to say that fast. What it does is it requires the hospitals to provide oral and written notice of observation status to individuals who have been in that hospital for 36 hours after they've begun to receive care in the observation status. 36 hours is a long time. You can be racking up a lot of costs if you're there for 36 hours. So I just call that to your attention. At least there's some there's some understanding that people should formally be advised of this. So the hospital has to explain to the person, they have to explain the person is an outpatient and the reason for that classification. It's generally somebody who's in the admissions office, who's somebody who has a, sort of a base level of all of these things. You're not being told this by a clinician. You're being told this by one of the support staff. And it outlines the impact on insurance coverage. And then the implications, this is the biggie, the implications for cost sharing coverage in rehab and skilled nursing. And we're going to talk about this in much greater depth. But if you are not admitted as an inpatient for those 3 overnights, those days of qualifying, if you're sent to a rehab or skilled nursing facility, it's not covered under Medicare in 99% of the cases. So we'll talk about that in a little bit more detail. So this is basically the Part A, because Medicare pays, as we showed on that slide a little bit ago when I showed you the slide of what Part A pays for. Part A pays for, among other things, the skilled nursing and rehab. So the Part A 3-day rule is you must have 3 inpatient days. They must be consecutive. The day you're admitted counts, but the day you're discharged does not count, because day 1 counts only if you're in the hospital at midnight. Now, by the way, you might want to, again, I said we're going to give copies of the slides because there's just way too much technical information that relates to observation status to try to remember all this stuff. The days that that you spend in the emergency room, those are not covered either. And also that this point is really, really important. You must be an official inpatient for those 3 days instead of just being in the observation status. So you can't just be in a bed with a gown with a bracelet on your arm and consider yourself as an inpatient. You have to have been formally admitted with the doctor writing an order justifying the reason that you're being admitted. So there won't be any coverage in a nursing home, even if you're sent directly there from the hospital, unless you've met that 3-day criteria, the 3 midnights. So there are many reasons why people would go directly to a rehab facility from a hospital. I mean, things like, replacement of it, knee replacement, bilateral hip surgery, stroke, you name it. But there's a lot of reasons why people would go directly from the hospital to the nursing home. But again, the only way that that's going to be qualified is if you meet all 3 of those criteria. That you have that you had the 3-day qualifying stay. The doctor has to also order inpatient rehab or skilled nursing services, because you have to have required the skills of a licensed person, not just somebody to help you with a bath or help you get in and out of bed. You have to have the needs of a licensed personnel, and you have to need those services on a daily basis. So let's talk about Medicare coverage in the nursing home, because I'm going to use those terms interchangeably. But when you look at Medicare coverage from day 1 through day 20, and I don't know very many people that have coverage, that have 20 full days of coverage, but let's assume you do. If you get covered for 20 days, Medicare pays the full cost of that, and you don't have any charges, you don't pay anything. And again, this is presuming that you've met all the other criteria and had the 3-day inpatient stay. On day 21 through 100, and having been in healthcare for 30 plus years, I would tell you, you can count on the head of a pin the number of people who've ever had 100 days worth of coverage. I mean, nobody stays in that long. And the reason to continue, what's not said here, is in order to qualify to continue to get Medicare coverage, if you're in skilled nursing or rehab, you have to show progress, and you also have to be able to tolerate 3 hours of therapy every day. Now, I'm sorry, I can't imagine somebody who's 85 or 90 years old being able to physically tolerate 3 hours a day. Now, that can be a combination of physical therapy or occupational therapy or speech therapy, but still, 3 hours a day is an awful lot of time. So most people max out at about 20 days, but let's assume you're in 21 or longer. Medicare pays all except the copay. And in this year, 2022, the copay is $194 a day. When I work with people one-on-one, I really strongly suggest that they pick a supplemental plan that covers the copay, because again, not all of them do. And if for some reason somebody is in a nursing home beyond 100 days, they're paying 100% out-of-pocket costs. And in this current year in Washington, D.C., a semi-private room is $117,000 a year, and a private room is $138,000 a year. So that's pretty staggering. But even the $194 copay, if somebody doesn't have supplemental insurance, I mean, do the math on that. $200 a day for 30 days adds up really quickly. Again, rehab costs, if you're not an inpatient, is 100% out of pocket. I'll just tell you a little story. When I was, I've been retired for, I think, 6 years. We probably within the 5 years before I retired, I was the director for all of the aging services and adult services for the city of Alexandria. So it was like aging or us. And we would get calls probably on the order of, at least 5 or 6 a month for people either from the individuals themselves or from their families who had gone from the hospital to a nursing home, having no knowledge of any of this, only to be shocked to find out that they had just gotten a bill for $10,000 or $11,000. And I'm like, wait a minute, what do you mean I have Medicare? Well, of course you had Medicare, and you do have A, and you do have B, and you do have a supplement, but you didn't meet the 3-day criteria, but nobody warned them. Now, whether or not that would have made a difference if they would have gone just in terms of nursing care, but I'm guessing if people understood this, they may be more inclined to try to go home and get skilled home health in their home. But it comes as a total shock to people to get a $10,000 or $11,000 bill when they thought they had Medicare coverage. So the question is, what can you do? Well, I have actually known people who've left AMA, people who have literally left when they find out that they're not admitted. I know people who've actually left the hospital. That's probably not the safest thing to do. But, at the beginning of the hospital stay, or at least within the first 24 hours, if nobody's coming to talk to you about it, I think you need to try to be proactive and ask the question, am I going to be admitted? And I would not wait 36 hours till I got a notice. It's obviously really, really helpful if you have somebody there as your advocate And I know many people they don't have relatives, but if there's a way to have an advocate to ask those questions for you, because honestly, if you're laying in that bed and you're really sick, you probably wouldn't be in that bed if you weren't pretty sick to begin with. So, having the wherewithal to even think about asking the question, I would hope that you can rally somebody to be your support person and ask if they can start asking these questions for you. You would ask what specific criteria or guidelines they use to decide you're in observation status. Then you also want to know, you'd want to ask what kind of treatments or test results or symptoms would have qualified you for the inpatient stay. In other words, if this was different, if I needed this versus this, would I have been eligible to be admitted? You also could try to ask your doctor to admit you or to reclassify you as an inpatient based upon whatever care or tests or treatment you need. And I think if it's possible for you or your support person to contact your primary care physician to say, can you please help me? Can you run interference here? Can you give a call or page to this hospitalist doctor who's covering and tell them, look, we know this about you. Because again, think about somebody who's known you for the past 10 years versus somebody who's known you for the past 2 days. So if you're able to get your primary care physician to try to intervene, to make the case about how severe your situation really is, what are the things that this person doesn't know about you, which may help to make the decision to admit you. And then I think at the very least, you need to speak to somebody in the billing department to estimate, what are your costs going to be while you're in observation status. Because as I said earlier on one of the slides, if you're somebody who doesn't have B, you are 100% responsible for this. Or if you have B, but you don't have a supplement, or you have a supplement that doesn't cover the coinsurance or the co-payments on Part B, you're going to rack up a really, really substantial bill. And so what can you do? You can file a complaint with Medicare, especially if your nursing home or your rehab coverage is denied. And there's a wonderful, the Medicare Advocacy Center. It's a very robust program and they're really helpful. There's a lot on their website that I put on there that you can call them, email them. And then there's the Medicare Bill of Rights is also on medicare.gov. And so there is an 800 number. And I would tell you that now that it's not open enrollment, you can probably actually get a human being on there, but you can get questions from them about, payments and coverage and observation status. And you can also file a grievance. So that's a really important thing to know. And the Medicare Advocacy Center could help you craft the message if you want to actually file a formal grievance to ask Medicare to go back and say, why was I in the observation status? Why wasn't I an inpatient? So there are some rights, but most of these come sort of after the fact, particularly if you end up in the rehab or nursing, having been directly admitted to the hospital. And this is not to be disparaging in any way, but I would tell you that most physicians don't know this. I think most physicians know what observation status is. Having worked in hospitals for almost my whole career and having worked with doctors in a variety of places, they have so much they need to know that a lot of this stuff just sort of, it's not in their repertoire. And so most doctors probably wouldn't know what the 3-day midnight qualifying stay and the admission to the nursing home. They would just know that they've got a really sick person here who they think is, they've been an inpatient for 2 days and we really don't want them to go home because they're really sick. So let's send them to the nursing home. And so that's not in any way to be disparaging about doctors. I just think, most of them just really don't know. So again, it's not the doctor's fault. I think that's just important to understand that. It's not the doctor's fault. It's not like they're trying to be the bad guy. So can we answer questions for you? I know that's just a lot of technical stuff to cover. Erica should,
A couple questions in the chat.
okay.
I will start with the first one from someone who said, this is happening right now to their cousin.
Oh,
Hospital
okay.
for 3 weeks, cardiac arrest, dialysis, etc. Surgeon wanted to do a procedure in a different hospital, so was transferred there. Oops. Transferred there, will be discharged tomorrow to a rehab facility, but this morning was told hospital B has not admitted him. Help. He has parts A and B and Medigap. This is in Florida. Perfect example of just what you've been talking about.
Yeah. And the question is, you know, what control does that person have over the situation? Who that, I mean, they're sick.
Mm-hmm. Yeah.
And the second hospital is, it has them in observation, or I'm sorry, didn't they hear the last part that you said, the second?
The second hospital,
Can I speak up so I
certainly
can?
may.
Yeah,
Sure.
you didn't quite get it right, but
Who's speaking? I'm sorry, who's speaking?
Gloria,
Hi.
thank you so much. I signed up for this knowing I should know about it. And then this morning, this very thing happened. And in fact, the proxy is on the phone. I'm holding it up to my laptop, so she's hearing it now. But he's been in hospital A in Florida for 3 weeks. He had cardiac arrest while there. He's under dialysis. There's a very serious, the surgeon who was going to do valve procedure wanted him transferred to a second hospital. He was admitted to hospital A, but not to hospital B. And we just found out that he's in observation status after just having this procedure for valve replacement, and they're going to discharge him. And we're just finding out that he in hospital B has only been there a day, and he's in observation status.
Why did they transfer him to this second hospital?
Because the surgeon felt that he has privileges at both hospitals, and
Okay.
that hospital B has has more experience in the procedure.
Okay, they probably have an easier parking lot too, but aside from that, wow. So the doctor cannot, they won't allow the doctor to admit him to this second hospital.
Well, we don't know that yet. We're trying to find out, but
Okay.
I'm sure he didn't give it a thought.
Well, I would tell you at this point, if you said there's an advocate there with this individual, I would say absolutely the doctor is the absolutely best positioned person right now to make the case to have this person admitted. I mean, it was under his order that he came there. Now, he doesn't have the powers of God, but he could well make the case that the reason that he transferred him there is because the hospital has more experience, and that he is going to follow him there. And so he could really lobby hard and try to make the case, because he's the one that's going to be doing the care, right? He's the one that's going to be following him. So he should really try hard to make the case to have the person admitted under his service, because that's the whole reason. I mean, that's the whole reason to have him transferred, right?
Yeah, but he's not going to be there 3 days.
He's not, has that already been determined? He's not going to be there for 3 days?
And I can't do both. So here's the proxy is asking me now. It's not that he's under observation, it's that he's not admitted as an inpatient. He's considered an outpatient.
Right, which is the
Same
same.
as observation?
Yes.
Yes, she says yes, Janet.
So is the goal to send him to a nursing or a rehab facility?
Rehab.
Okay. But he was an inpatient at Hospital A.
Yes, for 3 weeks.
Wow, interesting question. So if he had been discharged from Hospital A directly to the nursing home, that would have been covered
Yes.
because he met the 3-day qualifying stay. Wow.
Maybe I can contact you later.
Yeah, I really need to think on it. I probably would personally get on the phone and call someone at Medicare. I'm not guaranteeing that they would necessarily know the answer to that. But it's interesting because by transferring him to this other hospital, he's basically put him in a whole new category.
Yes.
Wow.
I'll contact you afterwards.
Okay.
Thank you. Okay, got that.
We don't often get real-time examples of when we're having our conversations. But I really would encourage you, and Erica, I'm sorry, I don't mean to overload you with a lot of emails, but there's just so much to digest. When I was putting this together, I thought, wow, this is kind of brain numbing when you put this all together. So
Well, I would be glad to send it out to whomever needs it. We have another question for you.
okay.
Medicare Advantage plans automatically cover Medicare B gaps.
Is that a statement or is that a question?
Do they automatically cover?
You have to look at the policy. Yes, probably 90% of them do, but you know, there's no guarantee.
Not automatically.
Basically.
And someone else wants to know, how do you know if you have Part B?
Well, you'd be paying for it. You would be, if you have Social Security income, it's deducted from your Social Security check. Part B is based on your income. Anyone who makes $88,000 a year or less pays $170 a month. Anyone over $88,000 a year, it's completely tied to your income, and you can be paying as much as $500 a month for Part B. But you know you have it because you have to have signed up for it. You have to proactively sign up for it. The same way you have to proactively sign up for A. So if you don't remember whether you did or not, that's a little scary. But it's deducted from your Social Security check. And if you don't get Social Security, you're actually writing a check for it each month. So let's say you signed up for B, but you've decided to defer your taking Social Security till 70. So the period of time between the time you quit your job, the time you're not working, so the time between you're 65 and you're 70, you're not taking Social Security. So you'd be writing a check to pay for your monthly premium for Part B.
That was my question. And I just want to say that I don't remember because when I signed up for it, I was a youngster and didn't have any idea of how complicated it was going to be. Thanks.
Most people didn't. Most people don't know. Most people are shocked. The thing that I think is so striking, and again, I won't repeat the Medicare workshop that we did, but I do training for a couple of organizations, one of which I'm getting ready to do next week, and it's employee training. And so it's part of their benefit package. And the thing that comes as such a huge surprise to most people when they look at how much they pay out of pocket for when you're employed and you have employer coverage, you might pay, even if you have family coverage, you might be paying $150, $200 a month at most. Well, the average Medicare recipient pays about $350 a month till you pay for your Part B, and then you buy a supplemental plan, and then you have your drug plan. And if you're somebody who's in a higher income category, there's a surcharge, so you pay more for B, and you have a surcharge, you pay more for D. So I actually was working with a client who was retiring, and he and his wife, because they look at household income when they look at B, and D, and because this individual had gotten a chunk of money as part of their retirement. For the next 12 months, this individual, he and his wife each would be paying $1,500 each apiece for their Medicare coverage with the B and the supplement, $1,500 each. So paying $3,000 a month for Medicare, the Medigap plan, and the Part D plan. So it is substantially more expensive than people think it is. Sorry, that didn't get on a soapbox, but it's.
No, that's all right. Next question. If you're in the hospital and have no support person or advocate and feel you need one, what options are available to obtain someone?
Really good question.
Really
If you're
good
part-
question.
If you're part of a village, I know that Palisades Village and several of the other villages collectively use Barbara Scott, who is the case manager, who is an MSW. I would say contact the village to see if Barbara would be available, just sort of help you run interference on this. I see that Barbara's on the call, so I think that would be really helpful. I know Capitol Hill Village has, I think they have a full-time MSW social worker. Not sure about the other villages, but if you're a village member, that's where I would start. Or if, perhaps, a lot of people have good supports in their church community. That's another place that I would consider if if you're not part of a village or your village doesn't have somebody to help you with that. I think your church, it doesn't have to be somebody who's medically trained. It can just be somebody who can speak on your behalf if you're just not able to.
Someone wants to know if you do consulting on a case-by-case basis.
I do. I set up because of my 130 years of experience with health and aging. I actually set up an LLC when I retired, Griffin Healthcare Solutions. I can buzz back to the last slide. It's got my contact information on there, my cell number and my email address. I can do that if you want me to, if I can figure out how
Or
to get
you can put it in the chat if you'd like.
Okay. I'm sorry. I don't know how to put it in the chat. I know ask questions in the chat. I don't know how to put it in the chat. Sorry. Okay, there. How's that?
Next question. Oh, you're not on sharing.
Okay, sorry. I will share. Okay,
No, it's not coming up yet. There we go.
there you go. Okay. So you've got email and cell on there. Okay.
All right. Oopsie. Barbara says she's here to help.
Hi, Barbara. I don't see your face, but I see your name. Barbara's incognito today.
Next question. In most instances, the hospital has a patient advocate to help the inpatients. If not available, the hospital administrator could be contacted from past experiences. That is a suggestion from the peanut gallery.
Yeah, I don't know if it's a question or not, but I think hospitals have, they call them patient advocates, even if you're in the observation status, and particularly if you've been told you're in observation status. But honestly, if you're hanging out there more than a full 24-hour day, barring extenuating circumstances, and I think COVID has really changed the landscape a lot. I think there are people who are just not being admitted because there's just not enough beds. But at any point in time, you can ask the nursing staff or the support staff to call the patient. Most hospitals call them patient advocates. You can ask that person to come and see you. They can also, I think, help you articulate questions to ask, and I think that's really important.
Next question. I believe you said Medicare beneficiaries receiving care in an SNF need to be improving and able to tolerate 3 hours of care for Medicare to pay. Does the
Correct.
JIMO decision clarify that Medicare coverage should be determined on a beneficiary's need for skilled care, not on their potential for improvement? Care could be for maintenance to prevent deterioration.
Yeah, there's a rule change probably within the past 2 years or so, because the goal is to get the person back. If you can't get them, you need to get them back to where they were before is the goal. And but I think in some cases, the nursing homes are still sort of functioning under the old, kind of classic rehab model of you have to have these and you have to be showing improvement. But even technically, to get them back to where they were before, you still have to be showing improvement.
Gloria is suggesting Deborah Levy Caregiver Group in our area has a well senior program. I have a caregiver assigned who knows me, so when I have an emergency, she can step in and serve as my advocate. She has a master's in gerontology, others are RNs, etc. Real comfort to me knowing I have someone knowledgeable and caring on my side.
Oh, great! Thank you for the information. That's good for other people to know.
Oh. And someone else is suggesting that Iona also has a program in which you can have a caseworker, have your records and act if necessary.
I
So
don't know that Iona, they have a wonderful case management program, but I think you have to have an established relationship with them. I don't think you can just do it on a PRN basis.
I believe you're correct, but I could be mistaken on that.
No, I mean, I think if you're an established patient, absolutely,
yeah.
they have an incredibly good case management program.
Does anyone else have any questions? We've exhausted the ones in the chat. Take yourself off mute and speak up because I can't see everyone, I'm afraid.
This is the fifth in our series of workshops. I've probably made more PowerPoint slides in the past 5 months than I have in my entire adult life. But I was chatting with someone and I wanted to know if, because some of you I think have been on several of these, and I was wondering if we sent out in a very short evaluation, even if today's your only day on here, if people would be willing to, answer maybe a 2 or 3 question, because it always helps to have feedback. I know I talk too fast. I mean, I know that already. So I try really hard to sort of slow down, but.
That's okay. I didn't see you. I was.
Sorry.
I couldn't get.
Anyhow, it would be good to have feedback.
That's fine.
Just in terms of going forward, if there's a time when we do these again, it's really helpful. Somebody's not on mute.
I have a question.
Oops.
I have a question.
Sure.
Is there a number available to get in touch with the Deborah Levy caregiver group? How would I go about finding that?
I'll
You can-
send that to the village. This is Gloria.
All right. All right, thank you.
And MaryAnn, your phone number is 571.
289-7306, but I can share again right here. Let me share.
Okay.
Okay. Okay. Thank you, everybody. It's been a pleasure to be on this call with you all. And on some level, I felt like I was delivering bad news, but far better to be an informed consumer than not, right?
I think that you're very correct on that this is one of those times when it's better to know that this exists and to be aware, because otherwise you're in an incapacitated state when this happens to you, and better to be on the alert.
Can I just step in? I happen to know about the Deborah Levy Elder Care Associates, and that telephone number for them is 301-593-5285, and they do provide a wide range of support services for the elderly.
And I put it in the chat.
Excellent.
Thank you. And MaryAnn, thank you.
Yes.
These months of work that you have put into this. It is so appreciated. And you've made all of us wiser consumers and better able to look out for our own well-being and to give us the information to share with others who can help us. And it is a gift that we'll keep on giving. And we really appreciate your knowledge and your experience. It's been
We've covered the waterfront, to say the least. I think there is no subject related to.
And
aging
thank you
adult.
to Palisades Village for allowing those of us from other villages to attend this excellent Zoom and for putting it on. Thanks.
we all play well together.
Yes.
The beauty of villages, yes.
Yes. About to celebrate their 20th anniversary next week.
Yeah, pretty incredible.
It's
I
exciting.
thank you also. Great job, MaryAnn. And I think we should do it maybe once a year, just because the more you hear it, the more it sticks in your head.
And it
Okay, you
changes.
mean
Because when
all
you're in the
5 sessions or
hospital,
just one?
when you're in the hospital, you're not aware of all this stuff. You just want to get out of there and get better.
Yeah. Exactly. No, that's important. All right. Well, everybody, thanks for being on the call. I appreciate it. And feel free to email Erica for the copies of the slides. Okay.
Thank you.
Thank
Thank
you.
you. Exit. Okay.
MaryAnn, this was incredible.
Thanks, Erica. Lots of stuff.